Now I will invite Dr. JASPREET SUKHIJA. He will be presenting lensectomy and ICL in jonulopathy.
Yeah, so the next way of implanting the IOL in these patients, anchoring the IOL, is you can do a posterior iris claw lens. So it's a PMMA lens with a constant of 117.2, what we use here. It's total length of 8 millimeters with a 5.5 millimeters optic, and you have these areas dips where you would like where the enclavation would take place. So this is the gap here, and these haptics are opposed to each other. So so obviously, I mean, you have these lenses here. Um, um, th- th- in patients, such patients with ectopia lentis, you would need to dilate the pupil, but for an iris claw, you would need to constrict the pupil. So this is a PMMA lens. So we have to have a larger incision in these cases. So a 3.2 millimeter incision, and the lens matter aspiration, of course, is done by making a capsulotomy, but it depends upon the amount of subluxation. You might not be able to do a lens matter aspiration if the subluxation is large. But yes, in those where it's moderate subluxation, probably yes, not away from the center, you can do a lens matter aspiration and then with the cutter remove the bag. And, and do a limited anterior vitrectomy if you feel that there's some vitreous tags coming. After that, the pupil has to be constricted, and then you can see this iris claw lens going in, which is a PMMA lens. The incision has to be large. So by holding the lens probably and taking one of the haptic back behind the lens, you just give a little nudge into the haptic, and the enclavation would take place. And the end point is, of course, a dimple which comes up there. And similarly with the other side, again hold the lens and then give a dimple, and then you can see probably uh, a round pupil basically, and the important thing is you have to suture hit. The pupil fairly dilates well, what you're seeing here when you're doing the irrigation aspiration. So the dilatation is not a problem here. The lens really remains centered over a period of 2 years, what we've seen. So some of the other cases, so this is a patient of Marfan syndrome. I'll be going a little quickly because of paucity of time. So again, we usually use intracameral dilators for these patients. You can see the pupil is constricted, but the moment we put that, it starts to dilate. You see the subluxation, the amount of subluxation, and as the pupil dilates further, you can see the stretch zonules as well here. So this patients usually have stretch zonules when the systemic issue is a Marfan syndrome. So the lens capsule is like sometimes very difficult to puncture. Uh, and the capsular access, again, as I said, I mean, in these patients where you're comfortable doing an anterior capsulotomy, the lens matter can be aspirated through this route as well. After that, the capsule can be removed with the cutter. So the first thing is, of course, a lensectomy using a cutter and the irrigation aspiration mode. So once you've done this, you remove the remaining bag and then do a limited vitrectomy, constrict the pupil, and then what you're going to put is a PMMA lens inside the bag. Sorry, I'll just show you how that's what we are doing. Holding the lens, taken one of the haptic back. Again, this is the other side. Just find the place where the haptic is. At least that's a little difficult, and then just simply nudge it. And that's how you can have a round pupil with a well-centered IOL. So it doesn't take much time. It's a quick procedure. This is just to show you that there are issues because these are Marfan syndrome. You might have to do surgery later for retinal detachment. So a dilatation of the pupil is very important. So these patients with posterior iris claw are dilating quite well. So this is another case. Now some of the complications which can occur with this lenses, as I told you, it's a blind procedure because the haptic has to go behind the iris, and then the nudge has to be given right at the place where where the gap is there between the two haptics, so as to uh, get the iris into that gap. So the first enclavation is not that difficult. But once you go to the second enclavation, when you're changing hand, if you're a right-handed person, probably it becomes a little difficult here, the nudge, because first because of the larger incision, the visibility decreases. So that causes an issue. And with a darker iris, it still becomes a little problem. So sometimes you end up basically having a very deep inclination. And what happens then is, at the end of the surgery, I'll show you what happened is, you can see here, I mean, the haptic has come right out of the, so one of the haptics where we knight it has come onto the iris. So basically now we know it's not going to disenclave because it's come above the iris. But then these things happen in such cases. So this is another case where we had the similar problem. So we're doing a lensectomy here, and I'll just go further. So this is the second part we're going to enclave. So that's it. That was the enclavation. It was done, a little dip. And what happens further is the pupil dilates fairly well when you're doing the irrigation aspiration. So dilatation is not a problem. Now you see this here. It's clearer here. So you see this haptic which has come into the anterior chamber. Now this IOL is not going to fall, but issues can come up because of the obviously iris atrophy and iris pigmentation, depigmentation which is going to happen. So these things do happen when you're doing such cases. Then you can have, the important thing is iris margin clipping, because it's a 5.5 millimeters and you have to go between the iris margin and the limbus where you need to enclave into the midstroma of the iris. So sometimes when the pupil is not constricted, that's the most important prerequisite. The pupil has to be constricted. It cannot be even mid-dilated. So if you have a mid-dilated pupil here, what happens is the edge comes, when you are pressing the iris, the edge sometimes gets into the haptic. So it's the iris margin which gets enclaved, you can see here, rather than the midstroma. So these are some of the things which you have to be careful of. I'm just bringing out the practical aspects. Disenclavation, this is the patient where we did the enclavation, which was fairly good. So the enclavation was quite good, but according to the surgeon, that was me. But after what happened after a few months, I'll show you. Look here, what happens. You can see something moving. I'm just trying to show you how the iris claw lens moves left and right, but doesn't disenclave even on vigorous shaking. So there is, you can see something moving behind it. That's it. So that's the iris claw. So it's not falling down. It has a good enclavation. So this lens had disenclavated because the child had some trauma. And if you see this picture here, you can see here that the iris claw is attached to the posterior surface of the iris, but it's nothing here. So it's disenclaved from one part. So this disenclavation over a period of time could be because of the iris atrophy, but many a times in the earlier period, it's the surgeon factors. Why surgeon factors? Because your enclavation has to be deep. Initially, once you do it, the enclavation is usually a shallow enclavation because you're afraid that you might drop the IOL behind. But over a period of time, probably yes, with experience, you learn that what is a deep enclavation. So those are the patients of syndromes, like we have mostly Marfan syndrome. Here we have something, a post-PPV aphakia. Now the important thing here is that even though the pupil is decentered, you can still place the IOL, enclave the IOL where a centration would be required. So the center part of the IOL would be in the center of the pupil, even though it's eccentric. So that's what I wanted to show you here, that these things are possible in any conditions. So we were able to do the enclavation here. You can see here it's slight oval, but once you remove the irrigation, do the irrigation aspiration, everything comes back. It's a post PPV, and probably yes, we were able to rehabilitate the child quite well. So I'd like to conclude here by saying that every case of ectopia lentis should be evaluated for its etiology. The type of surgery should be based both on the cause and the amount of subluxation. So it is not just the amount of subluxation, the etiology has to be known. I would preferably avoid iris fixated in those with iris atrophy. We need more evidence, long-term evidence rather. Posterior iris claw is a reasonable option in these cases. However, which is best would require long-term prospective studies. Thank you.
Thank you, Dr. Jaspreet. This is nice presentation, and not many of the people are doing iris claw lenses. Particularly, I think this appear reasonable if you place posterior iris claw lenses behind